Danny, maybe you can walk us through what it's like to give sub-Q Dara in the clinic.
Absolutely. So the pre-meds or the pre-medication and testing would be identical to what we would do for a patient who is actually going to receive the intravenous version of the daratumumab, but except the administration of the drug, it's different. You're going to give it sub-Q, like Dr. Char, you said earlier, better in the belly because there's a lot more sub-Q tissue in there, and it's given over 3 to 5 minutes. It's a very small needle, sub-Q, it's about 5/8 of a needle, so patients don't experience much discomfort, even though it sounds like a lot of volume, 15 cc's, because we all were learned in school that we are only allowed to give 2 cc's, the max, but you could literally give them 15 cc's. They tolerate it extremely well. Usually the first 4 doses is 5 minutes, and if they tolerate it well, it's given over 3 minutes itself. So I think it adds an extra convenience to our population instead of stating 7 hours or even minimum of 4 hours.
Yeah, I think to really emphasize, maybe Danny, you can talk about the nursing implications in terms of the staffing of a nurse to first dose monoclonal antibody for IV versus sub-Q and how that impacts the staffing.
It allows staff to be freer. So instead of a 1-to-1 for your first 4 to 7 hours of intravenous fluids, you may be giving the patient, then you're with them more than maybe an hour the most. So now the increase in chair time in your institution. So the patient, in the clinical trials, the patients were monitored for 4 hours. And if it does become commercially available, the monitoring will be a little bit different on patients. But again, your chair time is no more than maybe 1 to 3 hours maximum instead of 7 hours maximum. And the nurses then can move from one patient to the next.
Danny, I still remember when Dara was first coming on, we had that expanded access program. We started 50 patients on IV Dara in the span of 2 months. And so talk about chair time in the infusion center. Each patient is getting blocked not only for that long first day, but multiple hours every week after that. And it really put a big damper on the infusion turnover time.
And even in other institutions, they were starting them inpatient, actually. Many institutions were starting their first doses inpatient to see if they were tolerating the drug and then moved them to outpatient. So you're even exposing a patient to an inpatient environment or taking up an inpatient bed just for an monoclonal antibody. And then in that, again, coming out to the infusion center, you're still blocking at least 5 hours of a chair.
And I think another interesting question that folks may not be, who have not given Dara sub-Q, can you talk about what it's like in terms of what the injection site looks like, especially, let's say, in comparison to bortezomib and what that looks like the day of, the day after? What does it look like in somebody who's gotten Dara sub-Q?
Interesting enough, there is some slight swelling. It's a little bit different than bortezomib, where sometimes patients would get a redness or irritating of the skin. You still will get some types of irritation. Some people do get a red blotchy kind of discoloration at the infusion site, but it's very fleeting. It usually lasts about a day and it dissipates over that. But again, minimal amount of effects to the skin or discomfort to the patient themselves.
I've been really struck. I think I've shown up to a bedside after a patient got Dara sub-Q. I can't even find where the nurse injected. And I'm like, where did it go? So it's really hard to see. I think it's really well tolerated. I always say that when we compare Dara IV and sub-Q, or actually when we compare any medical treatments, we want to think about risk, benefit, and convenience, right? So risk here, we see lower rates of infusion-related reactions significantly, as low as 4% in DRD and Pleiades and 9% in the other arms in Columba. So less than 10% infusion-related reactions versus as high as 40 to 50% for IV. Efficacy seems to be comparable, both by the response rates that we've seen in Columba as well as Pleiades seem comparable, but also that important pharmacokinetic parameter called C trough was comparable. And of course, the convenience is really unbeatable. I always say that when I've been consenting patients to daratumumab subcutaneous clinical trials, the discussion goes like this. So we have a drug that's basically as efficacious, better risk profile, and is more convenient. Very few patients have had any issues. I mean, I think it's the easiest studies to get patients consented on, because who wants to spend more time in the infusion center? Danny, what do you think?
I think it's a great idea. And even though our patient population is the more mature adult, right? The average age is 69. They're still working, or even if they're not working, they still have other extracurricular activities. They're active, they're seeing their grandkids. And to waste it, to spend time in an infusion center for 7 hours compared to I'm going to come in for my shot, I'm going to spend an hour or two in the infusion center, and I can still go back to work. I can still go on a trip. I can still enjoy my life. I think when you look at patient satisfaction and convenience, I think that outweighs than having the intravenous wise.
Yeah, I always say, what's the point of having your myeloma be in remission, but you're chained to the infusion center all the time? So it's a great liberation from the infusion center.